Good morning and welcome to day 11 of the 12 days of articles in review. My name is Mary Coughlin and I am the president and founder of Caring Essentials Collaborative. Today's paper is looking at the effects of 4 approaches to oral feeding progression on the clinical outcomes of preterm infants. It was published in Nursing Research and Practice in 2015. The authors are Rita Pichler, Barbara Reyna, Paul Wetzel, and Mary Lewis. This is an open access paper, so when you hit the link on my blog, you'll be brought right to the paper, so you can download it, and it's really, really cool. So the authors, introduce a backdrop to why they've investigated these oral approaches to feeding progression with the understanding that transitioning from gavage to oral feedings is a clinical challenge for infants and caregivers. The who, the when, the how to advance oral feedings to achieve optimal outcomes was really what prompted these folks to study this. They employed a randomized experimental design with 4 intervention groups to prospectively test the effect of these 4 different feeding approaches, which I will describe shortly, on clinical outcomes to include time to full feedings, time to discharge, and weight gain during the transition from gavage feedings to full oral feedings. The 4 intervention groups are as follows. Okay, group 1 was early start, slow progression. So the individuals in this group were around 32 weeks post-conceptual age. They were introduced to feedings and gradually increased the number of oral feedings they were offered each day. Group 2 was an early start, but maximum feeding progression, progression experience. And so again, these guys were at 32 weeks, but they were offered oral feedings at every single feeding encounter. Group 3 was a late start. These folks had a postmenstrual age of 34 weeks, and then they were slowly progressed on their oral feeding experiences. And then group 4 was late start, so 34 weeks postmenstrual age, and maximum progressing experience. So they were offered oral feedings with every single feeding encounter. The participants, it was a convenience sample recruited from a level 3 NICU, 34-bed level 3 NICU. And the infants that were included in the study were infants whose birth gestational age was less than 32 weeks. They were receiving enteral feedings every 3 hours, and they were medically stable to take oral feedings by 32 weeks post-menstrual age. And of course, parents gave consent for the infants who did participate in the study. Each feeding approach had a 2-week protocol, and there were 2 levels of maturity. So as I mentioned when I described the groups, you were in the early start, which those folks were 32 weeks post-menstrual age, or the late start, and those folks were 34 weeks post-menstrual age. They, looked at all of the demographics. They analyzed the morbidity index on all of these infants, and then they followed the results. Now, parents were encouraged to provide the oral feedings in the study cohort, no problem at all. And anytime an infant received an oral feeding, the nurses were asked to record how the feeding went. If they weren't offered an oral feeding, why? Was it an infant-related behavior, or was it a non-infant-related reason for why the baby was not provided an oral feeding experience? And so overall, just kind of general information, the infants in the study groups, all groups, achieved full oral feedings by around 14 and a half days after being introduced to oral feedings, and went home on average about 21 days after starting the oral feedings. But once they started digging down and analyzing the outcomes for each of the groups, what they discovered is that the infants in group 1 and 2, those were the folks that started oral feedings at 32 weeks, they took statistically significantly longer to achieve full feedings and to approach the time for discharge than the folks in group 4. This was the late start group with maximum progression experience. They received an oral feeding encounter, oral feeding opportunity with each scheduled feeding encounter. Now, they may or may not have been able to take in all of the volume, and if they were not able to do that, the remainder of the volume was, given by gavage and stuff. But the infants in group 4 actually reached full oral feedings 9 days sooner than the early start groups, group 1 and 2. And they actually were discharged home 11 and 10 days sooner, 11 days compared to group 1 and 10 days compared to group 2. So that's a significant economic savings, as well as, human pain and suffering, savings as well. I mean, the longer these infants are in the hospital, the more traumatic and distressing it is for infants and families. So they also... this was an interesting thing. So they collected morbidity indexes on all of the infants, and there was no intergroup difference. So they just kind of looked at in relation to the clinical outcomes that they were observing. So time to full feeds and time to discharge, as well as weight gain. Does morbidity play a factor? And in fact, it does. The higher morbidity index was correlating to slower weight gain during the transition period, a longer time in reaching full feeds, and a longer length of stay. So again, interesting information that can help frame how we introduce oral feedings to the patient population. But in general, what the authors recommend is that delaying oral feedings till 34, the introduction to oral feedings till 34 weeks is a recommended best practice based on their findings. And there is no observed advantage in starting oral feeds earlier, nor is there any evidence to support that practice, although I know tons of NICUs across the planet introduce oral feedings at 32 weeks. There's some concerns around that practice, around energy expenditure and compromising the infant's skill development, because it's going to be very infrequent that they will actually have a successful feeding encounter. So are we really not doing them justice? And based on the results of this study, we're not doing them any justice by starting feeds earlier. In fact, we're lengthening their hospital stay. And so also, in the wake of some new evidence around oral feedings, introducing oral feedings, but actually not delivering an oral feeding experience with each feeding encounter due to non-infant specific findings. Now this kind of transitions into what I spoke about earlier about that missed care phenomenon. And in the Tubbs-Cooley paper, when infants exhibited feeding readiness behaviors but did not receive an oral feeding encounter, these individuals had a longer length of stay and took longer to reach their full enteral feedings. So overall, in the absence of evidence to support slow progression of oral feedings and this emerging evidence, the authors recommend that cost-conscious providers adopt this evidence-based best practice in delaying introduction of oral feedings until 34 weeks gestational age, and then offering these feedings routinely. I think this is really a great paper that really helps inform our practice that has been historically really kind of catch as catch can, based on historical practices that may not be founded in good evidence. So that's it for today's annotation. I hope you're finding these these little snippets clinically relevant. I will post the YouTube link as well as the blog link that will also have the video in it this afternoon. And until tomorrow, you guys, take care and care well.